afternoon. I'm Jessrid Carriel Agardelion from Southwestern University FINMA Medical School, and I'm a second year medical student. How are you today?
I'm good.
Oh, that's really good. So today I'll be taking your abdominal examination. And before we start, can you confirm your name and date of birth, please?
Chucky, July 28.
Okay, thank you. Thank you, Chucky. Now, this abdominal examination, I have to record all the steps that we have as compliance of our physical diagnosis class. So please sign this consent form that I have here. Okay, so Chucky, our abdominal examination for today involves me listening to your abdomen, and I'll also be doing some palpation, so I'll be touching your tummy. Will that be okay? Okay, do you have any questions before we start? Okay, also, do you feel any pain right now?
No.
Okay, that's very good. So now please lie on your back. Okay, and you can start. Will it be okay for you to take off your shirt, and I'll just drape you when you're lying down? Are you okay with the pillows? So before I start, I have to make sure that my hands and my stethoscope are pre-warmed. Also, my fingernails are properly cut or trimmed for me not to scratch or scrape the skin of my patient. And now I'm on the right side of Chucky. Okay, let's start our abdominal examination. First is we have to make sure that our patient is in a comfortable position with pillows on his head and with his arms on the side for us not to tense his abdominal area. And also we properly place a blanket on the patient right at the level of his symphysis pubis, covering his private areas but exposing his lower abdomen area. Okay, so we can start with inspection, and with inspection, what we have to check here is his skin, also his umbilical area, and also any peristalsis or any pulsation on his abdominal area as well. Okay, so as we can see here, Chucky has surgical scars and also stretch marks. Okay, and per conversation earlier, these surgical marks were from his previous appendectomy. So he has a surgical scar on his right lower quadrant, and he also had an explored laparotomy. So it goes from his epigastric area down to hypogastric area for his surgical cut. So he has a somewhat flattened right lower quadrant part of his abdomen, and his umbilical area has some deformation too brought about by the previous surgery. Also, he has some stretch marks right below the periumbilical area. Okay, so let's take a look. Temperature. No rashes or ecchymosis. No umbilical varices or any peristalsis that we can see, or any pulsation during inspection. Now we can proceed to our, also there's no distension on his abdominal area. Second part is our auscultation. So auscultation comes first before palpation and percussion, because our bowel sounds might affect our results during auscultation. So what we will expect here is some clicks, gargles, or stomach growls, which is what we call berberigmi, and these occurs at an estimated frequency of 5 to 34 minutes. So we can start with the right upper quadrant using the diaphragm of our stethoscope. Left upper quadrant, right lower quadrant, left lower quadrant. We can also listen on the epigastric area, umbilical area, and hypogastric quadrant. Okay, now I'll auscultate for bruits, and let's start off with the renal artery. For renal artery, it should be a few centimeters above the umbilicus and along the lateral edge of the rectus muscle. So presence of renal artery bruits is highly suggestive of renal artery stenosis. So it should be, I'll start on the right side. Okay. For the aorta, iliac, and the femoral artery, we also have to auscultate for bruits. And bruits on those arteries is due to turbulent flow brought about by atherosclerotic arterial diseases. So our target here is that we should not be hearing any bruits on those areas. So let's start with the aorta. Also, let's go with the iliac. And then femoral area, right here in the groin area. Okay, let's move on with our friction rub. So for friction rub, I'll auscultate on the liver area and also on the spleen area. So this sound is present in hepatoma, gonococcal infection, which is present in the surrounding area of the liver or around the liver, on splenic infarction and pancreatic carcinoma. So again, we should not be hearing again those friction rub on the splenic and liver area. Let's start with the liver area. Good. Now we're moving on to our next step, which is percussion. So I'll lightly tap some areas of your abdomen. So this time I'll be listening for any tympani or dull sounds on the abdominal area. And with my right index and middle finger, I'll tap my left middle pleximeter finger, and I will be tapping it gently on all four quadrants. So tympani usually predominates because of the gas in the gastrointestinal tract, but scattered areas of dullness from fluid and feces are also common. So let's start our percussion. It's almost the same process with a pulmonary examination. Let's start with the right upper quadrant. Left upper quadrant. So it's right lower quadrant. We also have left lower quadrant. Okay, so it's mostly a tympanitic sound on Chucky's abdomen. Now we can move on to palpation. So for palpation, I'll be pressing on some areas of your abdomen, Chuck, using my hands. Let's start off with a gentle palpation. For gentle palpation, it's an aid in detecting abdominal tenderness or any muscular resistance and some superficial organs or masses. So for gentle palpation, I'll just be using using my right hand. So with my hand and forearm on a horizontal plane, hands together, flat on the abdominal wall, and then I'll palpate on the 4 quadrants. So it will be just in a gliding smoothly, and then I'll just raise it just off the skin on all 4 quadrants. So press my fingers, which is all together on the abdominal wall. Now start palpating. Right upper quadrant. Then you have a left upper quadrant, just in a gliding motion. And right lower quadrant. Also have left lower quadrant. Okay, now we can proceed to deep palpation. This time it will be the same motion as I did on the gentle palpation, but now I'll be using 2 hands with my left hand's fingers still all together, pressing on the abdominal wall, flat, and again horizontal forearm and my hand, then my right hand pressing against my left hand while I do the deep palpation. And of course, this is very important that we have to observe any signs of discomfort from our patient. Okay, and initially I asked him if there was any sign of pain in any area of his abdomen. So luckily he doesn't have any pain. And now I can proceed with deep palpation. But in case that he said he has any pain in any area of his abdomen, then it should be the last part to palpate. Okay, so let's start with our deep palpation. Right upper quadrant. So our deep palpation will fully delineate any abdominal mass or also any delineate the liver edge, the kidneys, and of course the abdominal masses. Okay, so if there's any abdominal masses, and I wasn't able to palpate any abdominal masses on Chucky's abdomen. If there's any, then we have to characterize its location, its size, shape, consistency, any tenderness, pulsations, mobility, or resistance against my hand during palpation. Okay, so now that we did the palpation, we can move on to our next step, which is to measure the liver span of our liver by percussion. So I'll tap again on the right side of your tummy, since our liver is located on the right upper quadrant. And at this portion, I'll measure the vertical span of liver nullness. And this is using light to moderate percussion strike, because if we use the heavier strike, it will cause an underestimation of our liver size. So starting below the umbilicus in the right lower quadrant area, and we will be percussing, looking for an area of tympany, not dullness, and then we percuss towards the liver. Then we can identify the lower border of dullness in the mid-clavicular line. So again, below the umbilical area, let's look for area of tympany. Here, the lower border of this is the lower border of dullness. Now we will identify the upper border of dullness, and this time we'll be starting at the nipple line, percuss downward in the midclavicular line until lung resonance shifts to liver dullness. So let's start percussing. Okay, so Chucky has 7 centimeter span in right midclavicular line liver dullness. So that's within our normal range, which is 6 to 12 centimeters. Okay, so now we will proceed with the palpation of our liver edge. Now with my left hand behind the patient, parallel to and supporting the right 11th and 12th ribs and adjacent soft tissues below. So now Chuck, now I'll take, please take some deep breath in and out. Then I'll place my hand on your tummy, so on the right side of your abdomen. So press left hand upward. Okay, so our patient is quite thick, and we have to make sure that we are actually pressing the right part, 11th and 12th rib, to support those tissues, soft tissues, adjacent soft tissues. Now I have to lift my left hand upward, then place right hand on patient's abdomen to where I palpated the lower border of liver dullness. So fingers, now right hand on patient's right abdomen, lateral to the rectus muscle, which is about right here. Fingers below the lower border of liver dullness. Then I move fingers up while I lift my left hand up, pressing the 11th and 12th rib. Move my fingers up, press gently in and up. Can you take a deep breath? Okay, so liver edge should be felt as it slides down the fingers. Can you breathe in again? Okay, on inspiration, liver is palpable about 3 centimeters below the right costal margin in mid-clavicular lines. Then I have to trace the liver edge both laterally and medially. Okay, breathe in for me again. So when palpable, normal liver edge is soft, sharp, and regular with a smooth surface. Also, normal liver is slightly tender. So with our patient being really thick, I have to adjust the lift on my left hand versus the pressure that I applied on my right hand as I palpate during his deep breathing. Okay, so this time we will be performing the hooking technique, which is really helpful for obese patient. So let me try this hooking technique, and same thing, I'll stand on the right side of a patient's chest. Then I'll place both hands side by side on the right abdomen below the border where I palpated the liver dullness, about right here. Then press in with my fingers and up toward the costal margin. So please take a deep breath again for me, please. Okay, liver edge is palpable with the finger pads of both hands. Now let's percuss and palpate the dome of the bladder, and also making sure that we continuously observe any signs of discomfort from our patient. So normally the bladder is not palpable unless it's distended above the symphysis pubis, and we will first percuss for dullness and the height of the bladder above the symphysis pubis. Bladder volume must be around 400 to 600 milliliters before dullness appears. Okay, on palpation, the dome of the distended bladder feels smooth and round, and we have to also check for some tenderness. It's just right below your umbilicus area. Okay, I'm so sorry. Okay, thank you, Chuck. Yeah, so it's nilo on his part because of those surgery scars left. If I try to press it really hard, it tends to be, what is the sensation that you feel, Chuck? Is it, yeah, it's really uncomfortable to the patient, but it's not painful, right? So it's not painful, it's just that it's uncomfortable, and it's been a while that our patient tried to be palpated on that location. So let's proceed to our kidney. This time, I'll palpate for the left kidney. So, Chuck, I'll be placing my left hand behind here on your left side, left upper quadrant. Now, my left hand reach over and around to lift up beneath the left kidney. Again, we're on the left upper quadrant. And with my right hand, feel deep there. So I have to have an extra force on this, and also deep pressure trying to palpate our left kidney. So please take a deep breath. Okay. Again. Okay. Normal left kidney is rarely palpable, but if you really have like patient such as Chucky, then it has to have a bigger force, stronger force when you lift around the left area, and also when you palpate on the anterior side on the left upper quadrant area. Okay, so now let's go with the patient's left side. Okay, so if the kidney is palpable, describe its size, contour, and any tenderness. So far, with the pressure and the lifting that I had on Chucky's left upper quadrant, I wasn't able to palpate his kidney. But now let's palpate for the right kidney. Normally, right kidney is palpable, especially when the patient is thin and the abdominal muscles are relaxed. So with my left hand, we will lift up from the back, and right hand feeling deep in the right upper quadrant. So Chuck, I'll press my right hand on your right upper quadrant, and please take a deep breath. Okay, so let's again feel for a mass or any palpable kidney. Occasionally, right kidney is more anterior and must be distinguished from the liver. So lifting my left hand again, while my right hand, fingers all together, lateral to the rectus muscle, press it against the right upper quadrant while lifting the left hand. Can you take a deep breath? Okay, there. Okay, still on the kidney, I'll perform percussion to tenderness, or percussion tenderness. I'll now be tapping on your lower back, Chuck. So if the kidneys are tender to palpation, we have to assess percussion tenderness over the costovertebral angle. And pressure from my fingertips would be enough to elicit tenderness. If not, use fist percussion. Okay, so I'll use the fist and the ulnar surface of my fist, and have to use enough force to cause a perceptible but painless jar or thud. Okay, some also use the hand, and I'll also be topping it using the ulnar surface of my fist, and same on the other side. Okay, that's good. you. Okay, so let's proceed to our special technique, starting off in assessing for appendicitis, a possible appendicitis. Now, this demonstration is for the sake of performing the techniques, but as explained earlier, our patient Chucky had already had an appendectomy, so of course we can no longer he can no longer feel any we can no longer feel any tenderness or any pain using this technique. Okay, so let's start off with McBurney point. And the pain of appendicitis classically starts from the umbilical area, and it radiates, or it migrates towards the right lower quadrant. With the McBurney point, I'll palpate carefully for an area of tenderness, and it lies 2 inches from the anterior superior spinous process of ilium on a line drawn from that process to the umbilicus. So 2 centimeters from the anterior iliac process, and palpate the tender area for guarding, rigidity, and rebound tenderness. So I'll still be using my 2 hands, with my left hand horizontally flat with fingers all together, and my right hands pressing my left hand. Yes. Sorry about that. What was that? Is it the Nilo sensation? Okay. So for the Rovsing sign, we will be palpating, or I will press deeply and evenly in the left lower quadrant, then quickly withdraw fingers. It is positive when pressure over the left lower quadrant causes pain in the right lower quadrant. Okay, so same maneuver. I'll use my left hand on the left lower quadrant. Okay, again. Okay, so again, it is positive when pressure over the left lower quadrant will cause pain in his right lower quadrant. Okay, so there's 2 ways how to perform our Psoas sign. Now for the first Psoas sign maneuver, let me press your right knee, Chuck, and you lift your right leg against my right hand, pressing on your right knee. I'll lift it up. Okay, do you feel any pain? Assuming that if he does not feel any pain, again, he doesn't have any appendix at all. So if he has no pain at all, then it's negative for Rovsing. Negative for Psoas sign. If there's any pain elicited from that maneuver, then that's a positive Psoas sign. For the next maneuver, please roll to the left side, Chuck. Okay. And now I will extend the right leg at the hip. Flexion of the leg at the hip makes it psoas muscle contract, making the psoas muscle contract, and extension stretches it. Do you feel any pain? Okay. So increased abdominal pain is positive for Psoas sign, suggesting irritation of the psoas muscle by an inflamed appendix. So that is our Psoas sign. We will perform the Obturator sign, another special technique to assess your appendicitis. For the Obturator sign, I'll be flexing the patient's right thigh at the hip, so please, with the knee bent, and I'll rotate the leg internally at the hip. Okay. So this maneuver stretches the internal obturator muscle. Do you feel any pain?
No.
Okay. So that is negative for obturator sign. Right hypogastric pain is positive for obturator sign from the irritation of the obturator muscle by an inflamed appendix. So this sign has a very low sensitivity. Okay, lastly, we will perform the Murphy sign. During our palpation, if we have assessed any tenderness or pain on the right upper quadrant, then we will assess further for any acute cholecystitis using Murphy's sign. So for Murphy's sign, we can either hook the left thumb or finger or fingers of my right hand under the costal margin at the point where the lateral border of the rectus muscle intersects with the costal margin. Okay, so Chuck, please inhale deeply for me, please. So this forces the liver and gallbladder down toward the examining fingers. Watch the patient's breathing and note the degree of tenderness. A sharp increase in tenderness with inspiratory effort is a positive Murphy sign. So do you feel any? Can you inhale again? Can you feel any pain? Okay, any tenderness? So that is negative for Murphy sign. And a sharp increase in tenderness with inspiratory effect is again, that's the positive Murphy sign. Okay, so we're done with your abdominal examination, Mr. Chucky De Leon, and thank you so much for your participation. And as a summary, so on general inspection, we have not noted any abdominal distension, though there are surgical scars brought about by your explored laparotomy. Also, your with your appendectomy when you were like 16 years old, we have not noted or there's no evidence of hernia in your also any varices, umbilical varices, there's none. Also, the temperature that it's also normal. We have not felt any sudden coldness in your abdominal area. And there are no other rashes noted on the abdominal area upon inspection. Also, abdominal palpation and percussion were unremarkable with no evidence of hepatomegaly or any splenomegaly or any enlargement of organs. No pain or tenderness noted during assessment for possible appendicitis or for acute cholecystitis. Also, your bowel sounds were normal and no bruits or friction rub were noted. But to complete this abdominal examination, we can proceed further with rectal examination. But in summary, these findings are consistent with normal. It's a normal abdominal examination. So once again, thank you so much. And do you have any questions before we end this examination? Okay, thank you so much, Mr. Chucky De Leon.